My name is Mike Carmont. I'm a consultant trauma and orthopedic surgeon with an interest in sports medicine. I think looking back, my first interest in sports medicine started when I submitted a presentation to the first international consensus meeting for concussion in sport in Zurich. That was over 12 years ago now. And I was attracted to the actual demonstration of the interaction of science, medicine and sport. After that, I went to the Commonwealth Games as an event side doctor for field of play, and I saw some sports practice in action. And since then, I've been attracted to the precision and accuracy of the sports surgery techniques throughout my orthopedic training, and that's something I continue with my current practice. I'm currently president of the British Orthopedic Sports Trauma and Arthroscopy Association. Not really. All the patients I treat the same way. I try to use the best evidence I have in literature, and I discuss the treatment options of any particular problem, and we adopt those treatments. We've got to remember that the patients themselves choose what procedure they wish to have performed, and they need to understand what the outcomes of the treatment they select is. A typical case of this would be meniscal injury. Many years ago, people thought the meniscus was a vestigial structure within the knee, and following a tear, these would just be removed. But now we know the importance of the meniscus for loading and for stability and proprioception and nutrition within the knee. And what we now know that meniscectomy does lead to arthritis over the knee. Meniscal repair is not 100% successful, but in the majority of repairs, it does lead to a good recovery. And that allows our patients to return to sports and activity with less of a risk of the onset of arthritis as a result of their tear. No, I try as best I can to manage all my patients the same. I try and promote physical activity for all patients. It's very important if you're managing the social, recreational, or elite or professional athlete. I try and use standard, well-researched, best evidence techniques where possible to improve outcome. Yes, well, ACL surgery or surgery on the anterior cruciate ligament is probably one of the most classic sports injuries. It tends to occur in a young sporting population during sport, particularly ones which involve a cut or plant or a sudden change in direction, particularly popular sports like football and skiing. And whereas people may be able to adopt normal activities of daily living, the absence and tear of this ligament may mean that they cannot control their knee for returning to those sports, and as a consequence they have to give up on and not continue in those sports. The surgery for anterior cruciate ligament injuries is also fascinating. The surgical techniques have evolved over the past 2 decades. Whereas originally people were doing transtibial techniques to try and replace and reconstruct the ligament across the knee, now people are thinking of trying to restore a more natural anatomical appearance to the reconstruction with the use of double bundle and now more anatomical single bundle techniques. And this is one of the key components of sports surgery, in that to try and work out if these techniques themselves are actually an improvement is one of the significant challenges, because we have to have very accurate outcome scores and outcome assessments following this, and it could be that the small improvements we make aren't determined and evaluated by the outcome measures we have. For instance, the more anatomical single bundle ACL reconstructions, it has been suggested in some groups that these may be more prone to tearing and they have a higher number of re-rupture. But this could be because the knee is more restrained and adopts a more natural position, and that the reconstructed tissue has greater loads than the tissue placed elsewhere in the knee. Well, that's another interesting development. Over the past few years, people have reflected back to the consideration of repairing the anterior cruciate ligament which has been torn, rather than reconstructing it and replacing it, to actually repairing it. The body itself has its own tissue put back in the natural place. We've got to remember that this tissue has strained and then ultimately failed before reattachment, and so it is a very difficult thing to do. And with the use of scaffolds and matrices put inside the knee, this is something which is going to become increasingly common in the next decade, and science will show us whether this is an actual improvement or not. Well, platelet-rich plasma is the concept where you take someone's whole blood, you just take a sample of blood by vivisection, you place it into a centrifuge and you spin it out to its component products. You can then take a small amount of the serum, which is very rich in growth factors, and that has biological factors to promote healing and to enhance recovery, and you would then re-inject this into the athlete in an area of, say, degenerative tissue to try and promote healing. And classic areas for this would be problems such as tendinopathy or enthesopathies such as lateral epicondylitis, patellar tendinopathy and Achilles tendinopathy. These are very difficult problems to treat, and they're also reasonably common in the general population. Yes, elite athletes are a difficult group to compare. We know they'll use any trick or technique to try and get them back to return to play compared to their fellow peers as best as they can. They're prepared to go to extreme levels, and this may well mean that in terms of their overall return to activity, they're harder to follow and not directly comparable, because they will have better physiotherapy, better treatment modalities, and better rehabilitation techniques, and also better motivation too. And so the outcomes in elite athletes are possibly not comparable to those of the general population. There have been a number of studies which have looked at these, and once again it's very hard to show that the administration of these techniques show a definite difference in a randomized prospective study. For instance, at the elbow, Mishra from California, they showed a significant improvement of visual analog score for pain, but when this was compared in another group from Denmark using a randomized study of PRP, glucocorticoid and steroid, they showed no significant benefit of any of the treatment arms of the PRP compared to the placebo arms. Now, Achilles tendinopathy is another common problem. Suzanne de Jong and their group in the Netherlands have put a lot of research into this, and they found that tendinopathy is very common, that almost between 2 and 3 of every 1,000 members of the Dutch population will have Achilles tendinopathy. It really is a very troublesome problem. It's very chronic. The same group have looked at the overall outcome, and 5 years after all treatments, 40% of people will still have some element of pain and dysfunction. Yes, their symptoms may have improved, but they're no longer pain-free as a result of their problem. Varying studies have looked at the use of PRP versus the use of placebo concurrently with eccentric loading exercises, and these haven't shown a significant benefit. The tendon structure has improved and you get a more natural appearance to tendon, and it's thought that it's the eccentric loading exercises which are achieving this. Conversely, across the Atlantic, Owen's group, they've shown only a modest improvement also. So it can be very difficult to tell if it's the PRP which is making a difference. And this is why we do need to have randomized prospective controlled studies to try and work out these things.